Good afternoon, and thank you for joining us yet again on a different edition, a brand new one of the program Healthy Living. I'm Adesu Wasawagi. Today we're going to look at the orthopedics and you. What are the services they render? What do they do for you? Why is it that most often the time we'd rather go the traditional way when there's a broken bone or two? We do acupuncture rather than go to the bone setters themselves, that's the orthopedics doctors or orthopedic surgeon, as the case may be. I remember those days, the Mobi and all of that, how people are usually being rushed to that center. So today we want to look at the orthopedics and you, and I have somebody in the studio from the orthopedics unit from the University of Benin. He's a senior registrar there, and he's going to be talking to us today on the program Healthy Living. He's Dr. Kennedy Aloha. Happy to have you join us today, Doctor.
Thank you very much. Thank you very much.
Good. So the orthopedics and you, exactly what do you people do in that unit of yours?
Well, thank you very much for that question. The orthopedic specialty is a branch of surgery that deals on all abnormalities concerning the bone, musculoskeletal system. Okay, and by that I mean abnormalities such as fracture, that can arise from road traffic accident, from fall, or from any other trauma. Dislocation of the joints that may also arise either from trauma, road traffic accident, and so on and so forth. And of course, congenital abnormality. I'm sure most times you see children born with deformity of the legs or deformity of the hand. That condition also falls within the purview of the orthopedic practice. Okay. And then people with cancer of the bone, that condition also falls within the purview of the orthopedic practice. Okay. People with infection of the bone, such as osteomyelitis, that condition also falls within the purview of an orthopedic surgeon. Okay, so orthopedic surgery is a branch of surgery, as I've told you, that takes care of any problem concerning the bone and, of course, the musculoskeletal system. Okay, so we are truly in charge of that, of that area.
Okay, now let's start with the children, the congenital issues. You know that sometimes children are born with deformity in the arm, deformity in the legs, and often the time, particularly those that are not born in the conventional hospital, they just leave it as an act of God. Oh, make we live and they're spoiling for inside belly. That's what people will say. They say, oh, this one, they don't spoil for inside belly. So let's just leave it like that. Oh, it's one woman I had a fight with that now made the child's hand to be bent or one kind. So if such a situation arises, how do you advise patients?
Well, first of all, let me, with all due respect, correct that notion that you had earlier said. It's as a result of misinformation.
Exactly.
Okay. Rather than, attributing it to the art of divinity, enemy cause harm, this one cause harm. It's lack of information. Most people, unfortunately, do not know that we, the orthopedic surgeons, we are capable of correcting that lower limb deformity. And then another thing that also accounts for, lack of early presentation in the hospital is finance. Okay, I want to assure you that there is no bone deformity in children that we cannot correct.
None at all.
There is none.
So that means those children we see on the street with funny-looking legs. With apologies to those who have such a condition, we're not trying to make a joke with you or make a joke on you. No, we're trying to explain something.
Exactly.
In this country now, you have to be very careful what you say.
Exactly.
We're not discriminating. We're trying to explain something to you. You say some kids with some kind of deformity, bow leg, they say it go cover when it grow. But at the end of it, it does not come together. It remains. Then there are some with very serious conditions up to the point that they cannot work. That means if they had presented early, it would have been corrected.
Now, my profession, the Nigerian Medical Association, does not allow us to advertise our practices.
Yeah, I know doctors don't advertise.
So with all due respect, I need to quickly put this on table.
We are not advertising.
But for the purpose of this,
of this enlightenment,
I would like to say that deformities in children, what we call congenital deformities, they're actually born deformed. Okay, depending on the nature
of the deformity,
of the deformity and the types, because there are some deformities actually nuisance.
You cannot do anything about it.
There's nothing anybody can be
cannot even be managed.
None.
To just be like that.
There are some congenital deformities that are actually of nuisance value to the patient. Okay, such deformities, I'm very, very sorry to say, may eventually end themselves amputation. Okay, for that deformed limb to be gotten rid of, for the patient to now live a normal life. After all, we now have prosthesis, artificial legs that can then be recommended for such a patient. However, majority of the other congenital lower limb deformities, such as bow leg, K leg, one leg longer than the other. Yes. These are deformities that we usually correct. You won't believe it. A patient who, for any reason, was born with limb length discrepancy, who presents in the hospital at any age. At any age? Yes. Initially, patient may not be aware that such conditions can be, managed. In this country, for that matter, we do that. Okay, we are able to lengthen the other leg to ensure that both legs are now of equal length. Is it K leg? Is it bow leg? Whatever it is, we are also capable of correcting, that, deformity.
Is this procedure difficult? Do you have to break and rearrange, something?
Yes, it's a surgical procedure that requires, the bone to be broken in layman's word now, and then realigned. Okay. No, don't worry. Patient won't feel pain. No, patient won't feel pain.
Okay.
Patient won't feel pain because the patient will need to be put under anesthesia.
Okay.
Okay. So in the process of doing the surgery, the patient will not feel pain at all. Okay. And of course, most of the patients, patient relative that may be watching this program can attest to the fact that patients and patient relative were satisfied with the nature of our work. Okay, so it's something that they need not bother about. It is something that they need to come to the hospital, early enough. Okay, because there are some of the lower limb deformities. Okay, that that whose success is age dependent. Time of presentation of such patients in the hospital. Okay, some of these conditions, if surgery is done after the age of 5 years, the possibility of recurrence is always there. However, if they present less than 5 years and surgery is done before the age of 5 years, the possibility of recurrence is
at what age can a child go for surgery, bone surgery, such as what we're discussing about now?
Except for Blount's disease, lower limb deformity that we call Blount's disease. The disease was actually named after the person who first published it.
Okay.
He wasn't the one that first discovered it, but he first published it. So
how is the situation like this Blount disease?
Yes, this Blount disease, for instance, okay, it almost mimic rickets, a condition called rickets. Patient present with either bow leg or knocking, legs and all that. Such deformity, the success of surgery is dependent on age of presentation. Okay. Literature is well documented in literatures all over that if surgery is done before the age of 5 years, the possibility of recurrence is very, very minimal. Okay. However, most of our patients don't present on time.
That is the problem now.
They don't present on time.
When it comes to assessing medical
they don't present on time. That is the major challenge that we, the orthopedic surgeons, are being confronted with day in, day out. As by the time they present, it's usually too late. They need more resources, to now pull to be able to have that surgery done for their patients. Okay, and apart from that blount disease, any other congenital abnormality of the lower limb, okay, there are some that requires the patient to attain the age of skeletal maturity.
Okay, that's what age now?
Yes, 17, 18 years old.
Okay.
Okay, before surgeries, can be done. Okay, there are some that may require surgeries to be done, as soon as possible.
Immediately.
Okay, so it depends on the kind of, deformity of the lower limbs. It depends on the age of the presentation. Okay, but the truth of the matter is that most of our patients present very, very late. And the reason they always tell us is they don't get money. Okay, they have not even come to the hospital to find out, if the surgery can be done successfully.
That's not getting information at all.
The financial implication of the surgery, they haven't even come, but they just stay away.
No money, which is the usual practice. Okay. And that's a very dangerous thing to do. At least go to the hospital first, present your case, and see what can be done before you start crying wolf where there's actually no wolf.
Exactly.
Now, you talked about some bone disease, cancer of the bone, some other bone disease that can be done in your unit. Now, let's now look at cancer and what other bone disease, exactly what other bone disease can be treated and how you can do that. Let me bring to your mind why I brought this up was that once upon a time, one of my brothers had injury when he was young.
Okay.
He fell from a mango tree. And nothing happened. Nobody knew that something was happening inside. I think he fell when he was about 13, 14. And he didn't, he started having problems when he was in his late 20s. And by the time he got to the hospital, it was said that something happened to the bone. I was quite little. I just knew that he was complaining bitterly of heaviness in the leg, was having headache, and there was this swelling that my mother felt was a boil ripe enough to be removed. So she got a pin and just punctured it. And that was the beginning of the young man's wounds. There was pus everywhere.
Yes.
So why did it take that long for us to know that there's something happening with this young man's bones? Something that happened to him at 15 and it didn't start manifesting until it was close to 30, in his late 20s,
Yes. In the first place, what may have happened, of course, which is very common amongst young children, is that by the time they sustain any injury out of fear, they are not bold enough to inform their parents.
Okay.
They rather prefer to hide the injury, to themselves only.
For fear of being beaten.
Yes, for fear of being beaten. Some of them even go out of the way to confide in their friends who take them to other places for treatments without actually letting the parents of the patient know. Okay, and that's what I think really happened. In the case of this patient that you have just mentioned, from the way you have painted the history, this looks like a classical case of infection. Osteomyelitis of that particular bone in that area. Okay, it's an infection of the bone and the bone marrow. Okay, now what actually happens is that there's usually a focus of infection round either in that leg. Okay, you said he was a child as at that time.
Yes, it was, of course, a teenager.
In children, upper respiratory tract infection, otitis media, okay, boil in any part of the body, okay, open injury in any part of the body, sore throat, all this infection, any of this infection can spread to the site of infection, to the site of trauma in children, and this can eventually lead to what we call acute osteomyelitis when it is less than three weeks, and then eventually becomes chronic if it is not managed. That's what I think eventually happened. Management of chronic osteomyelitis is one of the most challenging, I repeat, it's one of the most challenging, treatments, that the orthopedic surgeon, ever faces. The reason being that the disability can become lifelong. Okay? Pus, draining from time to time, even after having the much desired surgery. Okay?
You still be draining
pus, can still be.
Yeah, it's very smelly pus.
Yes, okay. The reason being that once the bone has become infected, okay, the part of the bone that is mostly affected is dead. That's what we call sequestrum.
Sequestrum.
Yeah, it is now surrounded by a healthy bone. Okay, a healthy bone.
We now surround that.
We now surround a dead bone. So as far as that dead bone remains, pus will start, being discharged from there, until that dead bone and the little tiny particles are completely extricated. That pus will continue to be discharged.
Okay.
Only one surgical session may not be enough to completely remove the dead bone. You send patient back to the ward and observe. If, with repeated...
That you remove by cutting off that part?
Yes.
Then how do you now join the good part and the...
No, it's a special surgical procedure.
Okay.
That encompasses opening up of that part of the bone. Okay? And then curating, we call it initial suturization.
Okay.
Okay.
I'm trying to imagine what you're talking about.
Right now,
yeah.
let me come to the layman's point of view. Yeah. Okay. You have to curate. What is it called now?
Do you scrape?
Scrape, yes, that's the layman's word.
Okay,
at least
you scrape that.
That is the purpose of this, discussion. You scrape that dead bone out completely.
Now, will you not shorten the length of the bone?
In the process, the bone may fracture.
Okay.
Of course, that is not what we are concerned with. Fracture can always be managed.
It is the aim of that dead bone.
The aim of every surgeon who is managing a patient with chronic osteomyelitis of the bone is to ensure by all means necessary that dead bone is removed. Now, as I told you, it may not be possible to remove the dead bone in one surgical session.
Okay, it could take some sessions.
You remove the dead bone, okay, because once surgery becomes too prolonged in theater, it becomes, hazardous to the patient. Too much bone will be lost. Too much blood will be lost. Duration of anesthesia will be prolonged. Infection can, set in and all that. So for that
you
purpose,
have to be as short as you can in
at least 3 to 4 hours maximum. Okay.
3 to 4 hours.
Yes,
that
maximum.
One no short now.
Okay, and then you send patient back
to the ward.
Continue daily wound dressing. Okay, if within weeks of doing that daily wound dressing, you still see evidence of pus emanating, take the patient back. You still scrape and irrigate copiously. Okay, and then you take the patient back, place patient on antibiotics, and so on, so that even at that, it may still not be possible to completely scrape out all the dead bones. Also, patients may need to be taken to theater several times. Okay.
But eventually it can get cured.
Yes, it can get cured, yes.
Will it not shorten the length of the bone?
Yes, occasionally, chronic osteomyelitis may lead to shortening of the leg.
So one leg will not be longer.
One leg will not be longer, than the other. It is expected when the part of the bone that has been affected is very close to the growth plate in children. Of course, the growth plate is the part of the bone that is responsible for increasing length of the bone. A child who has not attained the age of skeletal maturity, the bones, in other words, have not fused yet. Child is still growing.
That's what child.
If such a child develops chronic osteomyelitis very close to the growth plates, to the lower or upper ends of the bone, that infection can damage that growth plate, thereby resulting in, shortening of that leg, and then with the other leg longer than that. Okay, but that is no problem. We can still lengthen the bone. Okay, once the infection has been completely eradicated.
Okay, that's for children.
Yes.
What about
even
in adults?
In adults, yes.
In adults, they can still be lengthy.
Yes. There are people. Sorry, like I told you.
No, what do you do? Do you add bones to the bone?
No.
I really want to know. Or how do you make it?
You see, I will say this again.
Yeah, we are really pressed
for the purpose of our listeners.
I want to get a promise from you that we're doing this again next week, Monday.
There's no
because
problem.
we have just like 2-3 minutes left for this segment so that we can continue. We have not done home accidents and all of that. I
will always make myself
available. Please,
yes.
On Monday we'll do a part 2. So
okay.
Continue.
Now, let me quickly say this once again, that, as doctors, we are not allowed to advertise our practice.
We know.
That is one major, rule that, the Medical and Dental Council has set for ourselves. We do not advertise. But, however, for the purpose of this enlightenment, it is important that this be said. Okay? Yes, in bone lengthening, we do not carry another bone to join.
Okay.
It is done under what we call distraction osteogenesis. You may not understand what that is.
Explain to us distraction osteogenesis. We need to know.
In distraction osteogenesis, what it means is that when a bone, under normal condition, a bone is broken, okay?
Yes.
What we call a corticotomy. That's what we call it. You do not completely break the bone.
Okay.
It's an improvised way of breaking the bone. The process is called corticotomy.
Okay.
If such a bone is gradually distracted, by distraction now, I mean if we use what we call an external physator, we call Lizarov device. When you come to the hospital someday,
I will call because of all of this.
Yes. It is gradually distracted at a rate of 1 mm or 0.5 mm per day. Okay, you distract it.
By distraction, are you?
By distracting that already broken bone, in quotes, downward, new bone will now be formed in the area that you have broken.
Okay.
Okay, is what we call distraction, osteogenesis.
And it's not something you do once.
No, because if you distract once, you will be subjecting the surrounding soft tissues, such as nerve, such as blood vessels, such as the lymphatics, the muscles. You'll be subjecting them to extreme, tension, and that can injure the surrounding nerves and the vessels. Okay, so it is done at a controlled distraction rate of 1 mm per day. First of all, you need to know to what extent you are going to distract.
Yes.
Okay? First of all, you compare both legs to find out the difference. If it is 5 centimeter or 6 centimeter difference. Now, for the purpose of this illustration, each of my finger is 2 cm.
Okay.
This one is 2 centimeter.
Okay.
This one is 4 centimeter. This is, 6 centimeters.
Centimeters.
If the difference between the normal leg and the abnormal leg is 6 centimeter.
Yes.
Okay, that means you are going to distract for that 6 centimeter
and
until
it's going to be gradual.
Yes, okay.
Well, Dr. Aloha, I wish we could go on and on and on, but we're going to take a pause here today with the assurance that we're going to do this again on Monday.
There's no problem.
All right, people, for the purpose of time, we're allotted time, so because time is not our friend, we will continue from where we stop on today's edition of the program. Hopefully, we'll be here live and direct again on Monday to conclude this topic. Thank you for finding time to be with us on the program. Dr. Aloha, thank you so much.
It's my pleasure,
continue on Monday.
No problem.
All right, we'll bring you a part 2 on Monday. Bye-bye.